some eminent personalities without Chandrasekharan Nair sir, our own Chandu sir, who is completing 50 years of teaching experience. His experience and fairness as a prosthetist of the highest grade.
Contributed to 19 textbooks. He has published 147 articles, national and international level. He has given 150 articles to the printer and social media. He has conducted CDE workshops, 130 till 2016, highest in the state of Kerala as well in India. He has given 45 invited lectures in the national level as well as international level, and more than that, the highest accolade is like this. He has conducted 40 teachers training program, which had huge impact the teaching community of India. It's not over. So he has occupied many spaces. So one thing is that he was the chairman of Board of Studies at Kerala University. Second, he was the editor of our prestigious KDJ. And the third thing is that he was the associate editor or maybe consultant editor of the National Prosthetic Society. Doesn't stop here. See, if a person is a giant, great. But if a person is icon, his contribution, your contribution is going to be there. So he has given to the Prosthetic Society, or he has invented, he has contributed 11 inventions. I can't commemorate the entire 11 one, but I'll tell you the best 3. The first is a racket. The plastic reinforced, like the fiber reinforced plastic. Second is Ananda, self-designed the semi-adjustable articulator, and Chandra, again the extra oral traces. The only one person from India who could have done this is our own dear Chandrasekharan. And seeing all his contributions, he has received 15 awards or maybe 15 accolades in his life. Again, I'll just go to the best only. So the Neo Literature National Award, 79 and 80. The Vaidya Award in 2007 by the Parshiraja Trust, and because of his entire lifetime contribution to the field of prosthetics and field of dentistry, Kerala Dental Council honored him in 2015 with Danta Acharya of Kerala State. A passionate teacher, by heart a prosthetist, and by soul a great teacher. What else to say? Who else to say? And the best man for us. So put your hands together for our own Danta Acharya.
Dr. Ethan Thomas, Vice President, IDA Kerala State, and Oromaxillofacial Surgery, HOD of Pushpagiri Dental College, to moderate the session.
നമസ്കാരം. എൻ്റെ മുഖം കാണാമല്ലോ, വലിയ പോലെയല്ല. കാരണം പലയിടത്തും ചെന്നാൽ ലൈറ്റ് എങ്ങാനും അണച്ചു പോയാൽ പിന്നെ എൻ്റെ ഷർട്ട് മാത്രമേ കാണൂ. അതുകൊണ്ട് ഇടയ്ക്ക് ചിലപ്പോൾ കുറച്ച് മലയാളം പറയും. മലയാളം അറിയാത്ത ആളുകളുണ്ട്. ശരിയായിരുന്നു, എല്ലാവർക്കും അറിയാം മലയാളം പറഞ്ഞാൽ കേൾക്കും. ഇംഗ്ലീഷിൽ തന്നെ പ്രധാനമായിട്ടും പറയാം. പക്ഷെ എങ്കിലും ഇടയ്ക്ക് മലയാളം പറഞ്ഞാൽ കുഴപ്പമില്ല. ആൾക്കാർക്ക് മനസ്സിലായില്ലെങ്കിൽ തന്നെ പൊക്കോളും. യെസ്. In my opinion, all these programs should be conducted by youngsters. But whatever new technology we learn, we include history also in 10th standard also. For the exam, one major part is history learning. By learning history, what do you achieve? All those things is debatable. So to include some part of history, the organizers have included me. Part of history. At least that is nice. നമ്മൾ പലതും വായിച്ച് ടെക്സ്റ്റ് ബുക്കൊക്കെ വായിക്കുമ്പോൾ കുറച്ച് വിക്രമാദിത്യ ചരിത്രമൊക്കെ വായിക്കില്ല, അതുപോലെ ഇങ്ങനെ വെച്ച്. സോ ബട്ട് വാട്ട് ആൾ ന്യൂവർ തിങ്സ് യു വാണ്ട് ടു ലേൺ, യു ഹാവ് ടു call in youngsters. But I can tell you some stories and in between I may ask you some questions. You have a pad with you, is it? Participants have a pad. You have a pen. So some questions will come. That answer first you try to score. Don't tell me. In public I will not ask anyone to answer because of the fear they may not. At 12 I will stop. Don't worry, because they have given. Because two young, vibrant endodontist are here. Because many of the questions asked to me was related to endo. They will come to my rescue. But the prosthodontic profiling of those questions I will do. Actually, that is a doubt for me. Finer explanations you can better give. Because our perceptions, we do not know whether it is same or different. Just look at this picture. Nice smile, reasonably good photo. The first question, do you like this smile? If the answer is yes, you put 1 and plus. So many questions will come in between. The second question is there an artificial element in this smile? If you feel yes or no, your answer you just score. Don't tell me. I will tell you the answer now itself. Then you can score. See this. The two centrals are beautifully restored. See, the lateral is natural. Maybe. So, all our people are very good. Our restorative dentists, our prosthodontists, they are all very good. And I also get the doubt, is it restored one or natural one? So, our people have the skill. For the skill, we should appreciate them. I feel so happy that our community is making wonders. If you also feel like that, why can't we give a great applause to our own brothers and sisters? We are really good. We dentists are really good, and we can make real wonders. See, another smile. The question is, it is natural smile, but can you guess the age of the patient? 20, 30, 40, 50. Anyone you can write down. Now I will answer. It is 40 plus. So by looking at the tooth, we can guess the age. So our restoration should match with the age of the patient. Then only we can say it is natural. See, in a 70-year-old man like me, if I am having beautifully arranged teeth, just like a 25-year-old youngster, it may not match. We cannot claim that it is natural. So we have to judge the age of the patient by looking at the teeth also, in our restorations also. See, maintenance is important for full arch fixed prosthesis. Now it is fashionable that we prosthodontists simply make so many restorations, full arch crowns, and maintenance part is neglected. Poorly maintained. That is why later it was all removed. So this can happen. We have to be cautious. And what is your maintenance protocol? What will you do? At least we can have our conventional brush and paste. We can have dental floss. We can have electric toothbrush. And the electric toothbrush is very good. It is accessible to many places. With our ordinary brush, even I find it difficult to clean the liquid surface of second molar. Very difficult at this age. The plaque I can feel with my tongue tip, but I cannot clean it with a great difficulty. But with the ease, I can clean it up with electric toothbrush. So electric toothbrushes, a 2 minutes timer, if it is incorporated, it will be very good. And 30 seconds, one beep or indicator, if it comes, then also it is good. I can change the quadrant. It is very good. And it must have a pressure sensor. If undue pressure I am applying with my brush, it should stop. Because otherwise, after some years, all these aberrations, then we can restore. Our people are here, experts, they will do it. But still, if the brush stops, with our handheld brushes, sometimes it is very difficult. All the cervical aberrations I can see. Even my own teeth, it is there. Next question. Can you guess the restorative materials used? It is all history. For youngsters, I just wanted to give you some history lessons. That is all. See, it is. Yes. Somebody wanted to answer? It is okay. Amalgam is perfect. Why don't you clap? Because these people can easily perfect. The other one they have written is silicate cement, even one generation behind. In our time, it was all silicate cement anterior restorations. I have given. Later, everything got displaced. GIC is very common. See, we prosthetists used to make such partial veneer crowns. And what is the name of the crown? Now nobody makes all these things. It is a 7x8 crown. A little, it is same thing, but 7 portions of 8, it is covered. But now nobody makes. Who has got time and who wants to wear this? A metal crown with a window here. Nobody makes it. And slowly we have come to this metallic crowns and metal ceramic crowns. All these things we have made and landed on our all ceramic crowns. Different types of all ceramic crowns. And ceramics also. In our time it was metal and ceramic mechanically bonded with the nail heads and all. It used to break off, we could not do anything in those days. But very soon our all ceramic crystalline structures, from feldspathic to crystalline, our zirconia, all those things. And now the third one, that resin plus hybrid ceramic. That has come. It may not be that strong. So all these 3 varieties are available now. See, all ceramic crowns are really good looking. Sometimes I cannot identify which is crown. How beautifully they incorporate that incisal edges and are very nice. Laboratories are excellent. At least we have to clap once for our good quality laboratories available. Very good. See, thickness of enamel of all them. We should have an idea how much is the thickness of enamel available on a tooth. Can you guess how much is the thickness of enamel in incisor, a premolar and molar? Just mentally prepare an answer. Anywhere between 2 to 3, if you write, it will be a good answer. See this. Name for the diamonds. Parts of the diamond. Head, the cutting area, neck, shank. And how much is commonly used diamonds? Length 16 to 19 millimeter. Diameter, we in prosthesis we use 1.2 to 1.6. Half the depth we are using for all our preparations of the cervical region. Half the depth. Full depth if you go, then you will create some problems. J defect. Afterwards we remove that, then it will be difficult to handle. See this. This is one. Just to show you a Comet brand. Fine grit. 46 micrometer grain size. So why I am showing this? Before using a diamond, you have to go through the literature, find out what is the cutting efficiency of our diamond. We usually don't go into that, whatever is available. And dentists have another name that we are collectors of partly used, half used, never used diamonds in a box. We keep it and take it. That is a custom because one patient told me, what do you search in that box? They are keen observers. One of my relatives went to a dental college recently. Lady, she is very observant. Then she came back and told me, you tell your friends in that college that cobwebs are there in that unit light. We won't see, patient can see. And to my luck, no spider was there. So go and read something about diamonds also. Can you guess the convergence angle in this shape? While looking at the cast after tooth preparation, can you? How much is the total convergence? That is both walls, opposing walls, how much? If you can, it is okay. Otherwise, you can note down, but answer I will. 5, 10, 15, 20, 25. Commonly used convergence is 10, 15 and sometimes 20. That is commonly used because we are human beings who prepare all these things. So it will be between 10 and 20 and nothing will happen. See this, total occlusal convergence between two opposing axial walls surfaces should be in the range 10 and 20 degrees. This is the convergence. This is how it is. That is 10, 10. It is inclined, then the total becomes 10 plus 10, 20. That is how it is calculated. Posterior teeth are prepared with greater convergence. Naturally, we cannot reach that place. That is why automatically it will become more. Mandibular teeth are prepared with greater convergence than maxillary teeth. That is because it is close to us, we can see and enthusiastically we prepare. Finally, especially the buccal surface, it is very close to us. Patient's right side, operator standing on the right or sitting on the right, cutting. Then that tooth will have maximum, we say prepare, but it is maximum damage. See the convergence. Next is, after tooth preparation, how much height should be there for the axial wall? At the end, we have to judge how much should be the axial wall height. It is 4 mm when prepared with 10 to 20 degrees. 4 mm height is a must. Less than 4 mm, you may not get adequate retention. That is why this is after the preparation, removal of occlusal table. 2 millimeters readily we will remove. Because all ceramic and all we are doing. Readily we are removing. So after that, the axial wall should have 4 mm height. That it is the measurement is shown. Now there is one ratio that also we have to be careful. The ratio of the occluso-cervical dimension of a prepared tooth to the facio-lingual dimension. See, occluso-cervical dimension, facio-lingual dimension. If that is 10, the length is 10, the other one should be 4 mm. And the ratio will be 0.4. That is a minimum. If it is not that much, great convergence will happen. If there is only 3, that convergence will happen. Only 2 means there may not be tooth also. So this we have to be careful. If 10 and 4, that is the ratio. Accordingly we can make. The ratio finally it has to be 0.4 minimum. See. Convergence is more. That is overzealous preparation. We have prepared. The crown can get unseated very easily. What will you do? That is a question. Just to think, I will try to answer. Just to think. I am giving you some exercise for your brain. That is all. Incorporate grooves. But now everything is compensated by good luting cements. That is why this is a little our history. But grooves can give adequate compensation for over-convergence. See, the mandibular crowns will get easily unseated because mandible goes from left to right on chewing. So the cusp will try to unseat. So the convergence should not be more. That shaded portion will resist the unseating in this direction, buccolingual direction. It will resist. Axial grooves boxes are used when mandibular molars are prepared for fixed partial denture, and they should be located where buccolingually the lower crowns can get easily unseated buccolingually. And earlier I said grooves or boxes we can incorporate. But where will you place? If your thinking is over, proximal surface. A box in the mesial or on the distal will be effective. See this. So that this portion will resist. It will not get unseated easily. Box on the proximal. For the same height, which tooth will offer better resistance, premolar or molar? Height is almost same. Just think, don't tell me the answer. Premolar, yes. Premolar gives. So unseating is not that easy with the premolar. If the structure is solid. If it is weak, then it may break. But when tooth conditions and aesthetics permit, finish lines should be located supra-gingival. That is a general rule. Because previously we were all for, as a student, I have done subgingival. Because that was the norm in those days. Now it is not. So, 1, 2, 3. 3 conditions I have shown. The white portion is the tooth. That picture you can identify, is it? Not difficult. Not everybody is shaking the head. Can you identify the picture? Yes. What is 1? Is it supra, sub? That only you want to tell me. Don't tell me. See this 1. Supragingival. Gingiva is here. 2. Equigingival. At the level of gingiva. 3. Subgingival. Below. So preference is for 1 and 2. Subgingival, nowadays it is not favored because of the biologic reason. What happens if it is going subgingival for our crowns? Because we are all known for this. We dentists, especially prosthetists, we prepare good subgingival. One word we have introduced along with this, that is the biologic width. See this. Biologic width is measured from the depth of gingival sulcus to the crest of the alveolar bone. This distance is biologic width. There is otherwise known as biologic zone, 2 to 2.5 millimeter. While preparing the crown, if you go and invert the attachment, this will receive, bone will receive, the attachment will get separated, a pocket will be formed. So our good intentions to restore the tooth will finally end up with periodontal disease. So never invade biologic width. That is why we insist on supragingival or equigingival. Now everybody is doing crowns and bridges. That is why I have opted for these questions. See this first. Healthy. How do you know it is healthy? Because you told me. No, correct. See that stippling. That is a good indication. If that is present, it is healthy. See here. Glossy, swollen, papilla very prominent. If you put a fine probe here, it will go into the pocket. That clearly indicates you have invaded the biologic width. It is not healthy. It is not healthy. Now, see the gingival termination, commonly known as shoulder. Everybody says shoulder. It is okay, no problem. But the shoulder was never a shoulder in our time. When we started, it was feathered, all metal. Feathered it was. And with the provisional, you cannot identify where it is. Finally, it is decided by the technician. Technician scrapes the cast and decides, this is your gingival termination. But now that is not necessary, because we are making it definite. Larger diamonds are used. And we make it equigingival. And we can, the probe will get stopped. When you trace the surface from incisal edge to cervical, it will get stopped. All round it has to be. It is not easy job to make such a crown with gingival termination. That is why now I have stopped doing all these things because at this age I cannot cope up with holding handpiece, looking at it with all big lenses. But magnification you have to use. and everything you will be able to see, and nice preparations. So you have to get trained on magnification and appropriate tools also that you will see through the magnification. That also you have to find. See this. Two popular gingival termination, the shoulders. This is radial shoulder. Inside it is curved and here it is flat. This is classic shoulder. In all ceramic restorations, usually this is used. Radial shoulder. And so if you are recommending an all ceramic crown or bridge, make the cervical region, the shoulder, a definite stop of 1 to 1.5 mm. That is what is said. Otherwise, technicians may not accept it. So, this one, see this, half the diamond should provide the gingival termination design. Half depth. But we are using a small diameter diamond, and on preparation, a J shape will come. Your probe will get stopped, but a sharp border will remain there. Later, when you fix the crown, in due course, that portion, see that red, it will get fractured. That will get fractured. So, when it is there, if there is a lip of enamel all round, if it is not having dentinal support, it will look opaque white. That should not be left as such. Try to remove that. Otherwise, later it will get fractured. Dentinal support for the enamel is essential. See this. This is the radial shoulder. This is. Inside angle. Angles should be rounded technically for preventing stress concentration and initiation of fracture. That is all. Tooth will get fractured later. Suppose we are not preparing anything and we are making metal ceramic crown. When you chew, approximately 400 to 500 pounds load you will apply. The felt force on the edges in metal ceramic crowns is 4,750 pounds, with which it will flex. If that force flexes the crown, even the metal is strong, the ceramic will get fractured on chewing. That is why we insist there must be a good quality gingival termination. Either shoulder or radial shoulder. It must be given in metal ceramic or all ceramic. Otherwise, fracture will be imminent. See, Schillingberg, 4th edition. Optimum degree of tooth preparation. Maxillary, anterior tooth, mesiodistal 10, facial-lingual 10. In our time, if what is the convergence given? 2 to 5. That was all we were telling. But that was humanly impossible. So this is how the 4th edition Schillingberg you can use. See, all ceramic crown fabrication, because that was a question. Even that was a question posed. That is why demand a significant amount of tooth reduction to allow. Why that tooth reduction is required? To make the restorative material thick, that is true. But why it has to be thick? Allow for a minimum thickness of core material. Usually layered or ceramics are used. So the core material should have adequate thickness. Second, to obtain good shade characteristics. Even in the cervical region, the shade selected by the clinician should be present. Otherwise, the core material will come to the surface and the layered one becomes thin. The required shade will not be there. It may become a little opaque. So, should provide reduction of 1.5 mm on the facial, 1.5 to 2 mm on the occlusal aspect. All line and point angles should be rounded. That everybody knows. Otherwise, because of stress concentration, your crown can get fractured. Ulceramic, even if it is zirconia, zirconia has properties superior to big-time metal alloys, but still zirconia can get fractured. See, now another test. If you are feeling sleepy, I can give you an exercise. Are you feeling sleepy? So many questions asked you. Any problem? The youngsters sitting behind, only youngsters, will you just stand up for 30 seconds? Please. Stand up, please. Only youngsters. If you feel you are a little aged, yes.
Yeah. All senior citizens in the front row, please be seated.
Nobody will feel no exemption to him.
Yeah. Yes, sir.
You can sit. Yes, please be seated. Yes. Because people are feeling sleepy. See, if it was an youngster and a film star standing here, then they would have been awake. All the history person walking here. And so, there are boxes and it is connected to some area. In the box, what has to be written? You just to go through and see. Do you remember the name? I'll give a little more time, 10 seconds. Do you remember? Okay, if answer is not coming also, it is okay. What is there? Long back you have learned in the colleges, then it is okay. But youngsters, they have learned very recently. Yes, this is the answer. Abutment, edgeless ridge, abutment, retainer, pontic connector. Retainer, pontic connector and all you should always remember. Abutment. Because in communicating with the laboratory, you should be specific. But now all CAD-CAM. You have to specify them. What connector? How much dimension should I require? Because it is all the computer decides. You have to tell them, I want this much. And here, the connector they have kept almost towards occlusal, because the embrasure space can be cleaned easily and papilla will remain unhurt. That is why. But now all these things are not happening. I have seen certain fixed restorations, entire proximal surface filled with ceramic and pressing on the papilla. And we are telling them clean it with the floss. To insert the floss, they may have to go to the dentist again. That is the condition. Yes, only superflows somehow it goes. Superflows, when I asked the medical store person, it was not available. So, from Amazon you can procure and give it to the patient. Tell, don't wash and reuse. After use, throw away. Otherwise, floss also, they may reuse. Don't do. See, all can prepared. But you can see that the convergence is too much, but it will go in easily. And you are using a high quality cement. resin cements you use, put it, because we don't want to remove it. Once we fix it, the patient should run away. They should not come back. That is our, every morning, what is the prayer we make? Let there be so many patients. Yes, correct. So many patients should come. And those patients should not include the patients whom I have treated before. That also we say. Because then it is headache for us. See, CAD-CAM. In CAD-CAM, it decides the area less than 4 into 4, that is 16 square millimeter connector. All ceramic bridges may not withstand our masticatory load. If you tell them 3 into 3, 9 square millimeter, they will make it, but it may break. That is why technicians take care. 16, but 16 square millimeter on the side, both sides, then cleansability will suffer. So the biologic profile of your restoration goes down. That will happen. And try to tell them, clean, superfluous, and never recommend toothpick. There are separate toothpicks for this brush, interdental brushes. But interdental brushes, will it go in? Have you seen interdental toothbrushes? Have you tried? You won't dare to try in your mouth. That is there. And I want to bring to your attention the tissue surface of the pontic. In all these CAD-CAM milled bridges, the pontic underbelly is not convex. Some areas are concave. And concave surfaces you cannot clean up with the flosses. That is the only problem. You can discuss with the technician, can you make it convex? Because it has to be cleaned up. Otherwise a foot lodged here will remain safely in that position for so many days, weeks, and all. But try. All these things we can say, but we cannot change anything. See this CAD-CAM framework. Can you see the connector failure? Here and here it has fractured. That can happen. As far as possible, don't give the ridge covering, that saddle type pontic. As far as possible, don't. It is not cleansable. See, this is ridge lap. Most of the lab-made bridges are ridge lap, modified ridge lap contact. Posteriorly, on the molar premolar region, if it is not like this, cleaning becomes very, very difficult. Our old sanitary, but technically it is hygienic. It is all good. Minimum 2 mm gap is there. But only problem is, it is cleansable. Only problem is, the patient, when they sit leisurely, they try to suck the cheek in and try to explore the area with the tongue tip. Then in train journey, like that. What are you doing? I am nothing. Just like serial conversations. What is the problem? Nothing. But a full set of problems. It is there. They are cleaning. See this. Underbelly is away from the tissue. And they clean it up and they suck hyperplastic mucosa sometimes happens. Hyperplastic, and later surgery has to be done. This is conical. This conical in CAD/CAM, I don't know whether it is there or not. It is not shown, but if it is conical, only a small contact, and the ridge should also be conical in cross section. Then only the conical bonding will be successful. If the ridge is wide and if you put a conical, food will lodge there. So it is not recommended, but mouthwash, brush and all will try to clean it up. Just spheroidal contacts. This is definite embrasure space. In CAD/CAM, how far you can make, I don't know. Because all these things, you raise the question. To the technician, you raise the question. Because our problem is, our requirement, we are not communicating with the lab. This is the problem you do. And most of the time, technicians will terrorize the clinician. I will give gap. But if it breaks, don't make a complaint. Then, in your lifetime, you will not raise a complaint. That is there. But technician also is helpless. Because in the machine, everything is incorporated. Connector, dimension, position, all those they fix. If we are not telling them, they will fix according to their wish. So you have to tell, is it triangular, square, round, everything you have to specify now. That is why the communication with the lab should be specific. So this is all questions.